Welcome back to the Thinking Mind podcast. As you may know, this is a podcast normally devoted to mental health and psychology. But something I've been meaning to discuss for some time are these new weight loss drugs, the injectable weight loss drugs, GLP-1 agonists like Ozempic and Mounjaro, which have recently become more available in countries like the US and the UK. Although these drugs have been around for some time, they've only recently entered the public consciousness, and given their impressive weight loss results and so far relatively good safety profile, these drugs are likely to make a big impact on the health landscape in the next few years, especially given the huge burden that obesity, diabetes, and related conditions have on the population. To discuss these drugs, I'm in conversation with Dr. Michael Camilleri, a gastroenterologist from the Mayo Clinic, who is specifically interested in how the gut moves, obesity, appetite, irritable bowel syndrome, and related topics. He himself oversees patients on these drugs and has participated in research investigating these medications. So today we discuss these GLP-1 agonists, drugs like Ozempic and Mounjaro, the ones which Dr. Camilleri thinks are likely to become dominant, their known side effects and safety profiles, what situations these drugs are likely to be prescribed in, what kind of results you can expect from them, possible additional benefits and drawbacks, and finally we discuss what kind of information we're looking for in the future about these drugs. This is the Thinking Mind podcast, a podcast all about psychology, psychiatry, mental health, and related topics. If you like it, there are a few ways you can support it. You can share it with a friend, give us a rating, click follow or subscribe wherever you listen, or if you want to support us further, you can check out the Buy Me a Coffee link in the description. Thanks for listening. Welcome back, everyone. Dr. Camilleri, thank you so much for joining us today.
Thank you for including me.
Normally, as everyone knows, this podcast is devoted to mental health and psychology, but a topic that I've recently become aware of and I really want to discuss because I think it's going to be so impactful to so many people is these novel weight loss drugs like Ozempic, and Dr. Camilleri is the perfect guest to be taking us through this today and separating fact from fiction. The first question I wanted to ask, I think what the drug most people are aware of is Ozempic. And coincidentally, today it looks like Mounjaro, the generic name is tirzepatide, just got approved for use in the UK as well. Are these the main two drugs in this category we should be aware of, or are there others as well?
Thank you. So the two medications you mentioned, which are Ozempic and Mounjaro, are medications that are administered once per week. However, there are other medications that certainly are available in the United States and maybe also in countries in Europe. For example, one of the first medications in this class was called exenatide, and it used to be administered 2 or 3 times a day, but now there's a once per week formulation. So it becomes much easier for patients who have either type 2 diabetes or who have significant obesity with complications of obesity, usually like high blood pressure. So it now becomes much easier for patients to have 3 medications at least that can be administered once per week. There's also another medication that's very often used for both type 2 diabetes and for obesity, and that is administered once per day. Its chemical name is liraglutide, and it comes by different names on the market like Victoza and Saxenda. Those may also be the names used in Europe.
Right. So I got at least 4 medications in this category that are relevant. Is it obvious at this point which one of those, if there is going to be any one that becomes the most dominant, and what might be the reason for that?
I would say that there are probably 2 medications that are kind of leading the pack. And they are leading the pack for 2 reasons. The first is the ease of administration by subcutaneous injection once per week. And those two that are currently marketed and approved are, as you mentioned, Ozempic and Mounjaro. The second reason why I still think that they may be leading the pack is that if you look at the degree of weight loss in patients with either type 2 diabetes or even more so in obesity, they appear to be 5 to 10% more efficacious than the daily subcutaneous injection formulations, which I mentioned earlier. So we're now seeing weight loss on average of 18 to 25% of total body weight lost in usually 6 or 12 months. And that is very significant from a metabolic standpoint because not only is there weight loss, but there's also improvement in such complications like high cholesterol levels or high blood pressure. And even there is evidence from large studies with follow-up that some of the other cardiac side effects of obesity, like ischemic heart disease and high blood pressure, may be significantly improved with these classes of medications.
Right, so it improves all of these interlinked problems, the cholesterol, the blood pressure, the weight, and it helps regulate blood sugar as well.
Indeed, these are some of the boons, these are some of the benefits that we're seeing with this group of medications that are targeting certain types of hormones. So they're mimicking certain types of hormones that the body itself normally produces. So because I'm a gastroenterologist, I'll tell you a little bit more about those hormones. So when we eat a meal, the food that goes into our intestine actually stimulates hormones like glucagon-like peptide 1, and you'll see this abbreviated as GLP-1, and another hormone called glucose-dependent insulinotropic peptide. That's a bit of a mouthful, so we try to summarize it as GIP. And the way these medications work is that, first of all, they stimulate the cells of the pancreas that normally produce insulin, and that allows the blood sugar to be better controlled. But these medications also have effects on appetite in the appetite centers in the brain. And what we and others are focusing on and demonstrating is that they also have an effect on stomach emptying. So people feel full with a smaller amount of food eaten, or the food stays in their stomach for a longer period of time, so they don't have an appetite to eat the next meal so soon.
So it's mimicking hormones that are released when food is eaten. It's delaying the emptying of the stomach, and it's also acting in the brain to reduce the appetite. Is that right?
That's absolutely right. That's a great summary, Alex.
Anecdotally, I've heard that these drugs can reduce someone's appetite, particularly for foods they shouldn't be eating, like junk food. And is that the case?
I don't know that that's actually been formally demonstrated in any clinical trial. It's not a focus that I have seen mentioned in the large studies that have been done to demonstrate the efficacy of these medications.
Okay.
So I'm afraid I don't know the answer to that question.
How long have these drugs been around? Because it seems like they've only just come into the public awareness, but have they been around for some time?
So I'll start from the beginning, if you wish, and studying the hormones that I mentioned, that GLP-1 and GIP, those studies actually go back at least 15 years. And the earliest GLP-1 agonist, which I also mentioned earlier, exenatide, which needed to be administered 2 or 3 times a day, that's been around for at least 10 years. What's really novel is the fact that in the last 5 or 6 years, the 1 time a day injection, which is liraglutide or Saxenda, that became available and came on the market. And in the last 2 or 3 years, we now have these 1 time a week injections like Ozempic or Mounjaro being introduced into clinical practice and being approved by regulatory agencies. Oh, and incidentally, There's also now an oral formulation that you can take as a tablet once a day of semaglutide, which is the equivalent of Ozempic. So, if people are able to take tablets, but they're skittish about taking subcutaneous injections, there might also be an alternative for them.
Right. Are there any dangers to these drugs? Are there things we should be worried about? What are the kinds of side effects that people can expect?
Thank you. So I'd like to mention a couple of points here. One is that when these medications are stopped, then there could be a rebound in the weight, and there's been documentation that the weight can actually go back almost to the same level as before the patient actually started the medication. So we have to think of that, even though it's not directly a side effect of the medication itself, it is an adverse effect, if you wish, of the administration of these drugs if we're not continuing them forever and ever. But that brings a point. Do we know how safe they are if they are administered forever and ever? And that's why I mentioned the point, because we still do not have that very long-term safety information. So that's the first point. The second point I'll make, and this has become a significant factor, at least here in the United States, with declarations and information from the Food and Drug Administration, that these medications can sometimes slow the stomach or slow the intestine to the point where there could be complications. So, for example, about 1 or 2 weeks ago, the Food and Drug Administration issued information that there could be a slowing of the motor function of the intestine, such that the intestines don't move food normally. There's a technical term for that, but we don't need to worry about it, okay? The other thing that can happen is that the emptying of food from the stomach can be slowed significantly. Now, why is this relevant? This is relevant because you may have seen an article in the Daily Mail a couple of days ago. There was a patient from Australia who actually suffered the problem of aspiration, which means that the stomach wasn't emptying well, and the food went from the stomach into the lungs, and unfortunately, the patient had complications and passed away. That is not a common problem, but we've got to make sure, for instance, if the patient is going to have an operation and they're going to have anesthesia, or they're going to have an endoscopy under sedation or anesthesia, there is a risk that their stomach is not emptied completely, and when the doctor is placing the tube, for instance, in the swallowing tube or into the stomach, that this evokes a vomiting response, and some of that vomitus may end up in the lungs, in the windpipe and in the lungs, and that could cause quite significant lung aspiration problems. So there are recommendations, for instance, from the American Society of Anesthesiologists has provided recommendations as to when these medications should be stopped if the patient is having an elective operation. So the problem, of course, is that there isn't very strong evidence to guide us with exactly the right number of days to wait before the operation. But the current recommendation is that with that liraglutide once a day, we should stop the medication at least 1 day before. And with the weekly medications like Ozempic and Mounjaro, we should stop at least a week before the operation.
Mm-hmm. And no doubt, as other complications become evident, new guidelines will have to be updated in order to deal with the problems that arise.
Absolutely. I did say we don't have the data, and hopefully in time more information will be available to provide more formal and accurate guidance. And I'll explain why, if I may. When you give a medication by subcutaneous injection once a week, that medication is usually in the body probably at high enough levels to have effects on the stomach for at least 3 weeks. And so a conservative approach would be maybe we should stop that medication for 3 weeks if we're having an elective operation, let's say a hernia repair or removal of a gallbladder or a lump in the breast that is going to require an operation. So for things like that, that are elective operations, a more conservative approach might be to wait 3 weeks rather than 1 week, which was the current recommendation.
You mentioned that how long someone can take these drugs for is very uncertain. We don't have the data. At least we don't know if they can take them indefinitely. Do we know, what minimum amount of time someone can take them safely? Can they take it for 6 months or a year or 2 years safely?
Yes, so there are actually clinical trials with safety data going out at least 18 months. It's possible that there are some others going out to 2 years. I don't think I've seen any that go beyond 2 years that have been published in the medical literature. So we do have some pretty good information about certainly 18 months, probably up to 2 years. And over time, there's going to be more information about safety that will be available.
Right. And is there any evidence that even after stopping a drug like this, there can be more permanent side effects, like, for example, more permanent slowing of the GI tract or nausea or vomiting or diarrhea or whatever it is?
Unfortunately, there is no such evidence that I am aware of. In other words, it does appear that if the patient has stopped these medications because of some of the side effects that you mentioned, for instance, nausea and vomiting being the most frequently encountered, then it appears from everything that we can identify in the published information that the side effect should go away.
Right. One problem that was highlighted by another doctor in America, Dr. Peter Attia, he was talking about these drugs and he mentioned something which is important, I think, which is that, we talk about weight loss as though it were synonymous with fat loss, and that's how we think about it. But of course, people can be losing weight in the form of bone density, muscle mass, connective tissue. Is there a concern that while on these drugs, people aren't just losing fat, but can in fact lose a substantial proportion of muscle tissue, skeletal tissue, etc.?
So I don't know the answer to that question for all medications, but I can tell you that some research that we did here at Mayo Clinic actually included a type of evaluation of fat mass and muscle mass when we did research with liraglutide. That's the medication that you take by subcutaneous injection every day. And when we studied patients over 16 weeks of treatment, and they had achieved the highest recommended dose, we actually did not see a significant loss of muscle mass. We only saw a significant loss of fat mass. I have to specify that is the one medication administered only for 16 weeks, which is about 4 months, and I do not know that information for the other types of medications.
Mm-hmm. And I guess we don't know, for example, how much protein they were consuming, whether or not they were doing something like resistance training or anything like that.
Exactly, and that's a very important factor because that could also have impacted the preservation of muscle mass and the loss of fat mass. What I can tell you is that in most of these studies, which are conducted with guidance from regulatory agencies like the Food and Drug Administration or the European Medicines Agencies, almost invariably, it is required that the patient received instruction and about diet and lifestyle modification. So, in some respects, when we say a study has been done with a certain medication and it was compared with placebo, which means an inactive medication, it's important also to stress, that they were actually also being given advice and guidance, and often the studies are conducted with phone call conversations and follow up at defined periods of time. For instance, in our studies, we did it every 4 weeks. And the patient had information with a dietitian and with a psychologist. So most of the studies actually are quite well um, informed from that perspective, although exercise is not typically monitored as a concomitant lifestyle change.
And do you think for patients taking these drugs, then, that it is indeed good rule of thumb advice to be making sure they're prioritizing protein intake and that they are doing some form of resistance training to stave off loss of muscle tissue?
I think that's a very, very good idea. And I also think the success story that I've seen clinically with many patients is that while they're on this medication, this is the time to change the lifestyle, to change the way they exercise, to change their diet, to learn from the dietitians that are counseling them in order to redress or improve their lifestyle after the medication is stopped, because there might be a clinical reason why the medication is stopped. Let's say they develop significant nausea, which doesn't go away, or they, might have other reasons why the medication needs to be stopped. Sometimes, in certain countries, the insurance may no longer provide access to that medication. And so this is a great window of opportunity to have those lifestyle changes, which are going to be important in the long run, to maintain the weight loss rather than a reversal back to the pre-treatment weight.
Yes, because as you said, there's evidence that once people stop the drug, it is very possible that they gain all the weight back, which is very typical of diets in general. Like, a lot of people feel like it's a struggle to lose weight, but actually many people can lose weight even without these drugs very successfully. And it's actually the maintenance of the weight loss that's so difficult. And I believe that's partly due to a person's hormonal profile. When they've lost a significant amount of body weight, all of their hormones have changed in the direction of wanting you to be more hungry and to put all that weight back.
Yeah, that's certainly a possibility. I do think that a real benefit from these new medications is that whereas diet and lifestyle typically was associated with a 4 or 5% average weight loss, and the medications we had previously, like phentermine topiramate, for example, would sometimes lead to about a 7 to 9% weight loss. These medications, especially the more recent ones like Ozempic and Mounjaro, we're now talking about an average of 20% weight loss. So, I do think that when people were on diet and lifestyle interventions and they lost 5% of their body weight, they weren't encouraged sufficiently, I think, to continue those lifestyle interventions. But the boon, the bonus, if you wish, of a 15 to 25% weight loss over a period of 6 months to a year with these medications really constitutes an incentive to continue with the lifestyle interventions that had been so successful together with the medication in reaching that approximately 20% average weight loss. So I look at it as a really good way to rehabilitate the way the patients think about food and diet and also lifestyle and exercise, as you said, focusing on the type of exercise that's going to enhance muscle mass.
Yes, and I suppose it's just all the willpower that a person no longer has to use to control their appetites, which, as we all know, is incredibly hard. All that willpower can then be directed in changing your lifestyle, changing your exercise, and things along those lines as well.
Absolutely, I think that's something which patients tell you that this is now um, almost like a new day. It's a new era where they've obviously gone through many cycles of trying to lose weight with different exercises and different programs for diet. But this provides that additional bonus that facilitates adherence to those lifestyle modifications.
Do you think these drugs can help us change the public perception of obesity as a problem? Because many people, I still think, view obesity as a kind of a moral failing, a failing of someone's constitution, their inability to exert self-control. And that argument really doesn't make sense in light of the fact that 2/3 of the population in Western countries are overweight or obese. Never really made sense. Do you think? I mean, my understanding is you've always advocated the idea that obesity is largely a consequence of our difference in appetites, and that some people simply have a higher appetite than others. So, do you think these drugs can help us change our attitudes in that respect?
I really do think that they can, especially when patients experience what we've just been discussing, which is the success story. And, the moral failing it's almost accusatory. And I think we need to avoid such categorization. I do think that by people realizing themselves that they can lose weight with these medications, they can get better diabetes control, that it will foster a better attitude towards diet and lifestyle intervention and help to facilitate the reduction in appetite. And I just want to build upon one other point which you made, and that is that I have seen patients who had type 2 diabetes, which was not controlled with pills, with medication taken by mouth, such that they had to go on insulin several times a day. And of course, what happens with insulin is it increases appetite. So even more so, the patient then puts on more weight and it becomes very difficult. The diabetes gets worse, so more insulin. And I've had a few patients that I personally looked after where, just to pick up on the point that there is a hormonal opportunity, okay? What happens, we talked about the hormones in the GI tract, in the intestines, that normally stimulate the pancreatic hormone insulin to maintain normal blood sugar. So I have a few patients in whom, by introducing medications like Ozempic, they were the ones that I had tested because this was in the last few years. So Mounjaro was not immediately available to us. But certainly with that medication, I was able to get very good blood glucose control. I was getting the glycosylated hemoglobin, also called hemoglobin A1C, down towards or completely normal, and completely stop the insulin. So the point is that their pancreas cells were still able to make insulin, but the hormones in the GI tract were not strong enough to stimulate the pancreas cells. So again, this taught me the lesson that indeed with obesity and the loss of those hormones in the GI tract, there may be type 2 diabetes that's happening because the intrinsic, the endogenous, the intestine stimulation of those pancreatic cells that produce insulin was insufficient. And so again, it illustrates the principle that you were mentioning, and that is that there are reversible changes in these hormonal effects. And sometimes by supplementing one of these hormones, in the case I mentioned it was GLP-1 on its own, it was able to restore not only normal weight, but also normal blood sugar and virtually cure the type 2 diabetes. Now, it's not cured because I still have to give the patient the Ozempic to keep the blood sugar under control. But at least I was able to stop the patient's need for insulin, which in the cases that I witnessed personally was also associated with an increase in appetite and an increase in weight. So I thought that would also illustrate some of the potential reversibility of the abnormal hormones which happen in patients with obesity in the case I'm mentioning with regards to those hormones that come from the GI tract.
Yes, and something that's probably under discussed in the treatment of type 2 diabetes when patients become insulin dependent is that obviously giving insulin, supplementary insulin, helps in the short term, but in the long term, it does contribute to the positive feedback loop of the illness itself. Is that not right?
Yeah, I think so. Patients really become more and more convinced that they have a significant medical illness, which is the type 2 diabetes. And it's now become so significant that my doctor has given me insulin to control the blood sugar. So it does sort of perpetuate this mentality of chronic illness. And I think this is another experience that we've had clinically with regard to enhancing the overall health of patients with obesity and type 2 diabetes.
Something else I've come across anecdotally is that people on these drugs can experience not only a reduction in appetite, but a reduction in certain other addictive behaviors like smoking, alcohol use, etc. Have you come across that? Is there any evidence?
I've come across some of that literature, particularly in regard to alcohol use. I must admit, I'm not an expert in this area and I don't follow that literature too closely. So I think I'd better not try to answer questions on those addictive behaviors. But, you know, from the perspective of other illnesses and psychiatry in particular, it's very relevant that medications, and this is your expertise, are sometimes associated with significant weight gain. And it's interesting to see whether these medications might also be applied in patients with who need antipsychotic medications. Maybe I should ask you the question.
Yeah, I mean, certainly if we knew that these drugs could be co-prescribed with antipsychotics, that would be a huge step forward for us because for some people, antipsychotics are just a necessary part of a patient's regime that helps them live a normal life. But one of the major downsides of antipsychotics, particularly the newer ones that came out initially in the 90s, is that it causes an enormous increase in appetite. So, like olanzapine is the obvious example of this. If there was a drug like Ozempic, which could be co-prescribed, that reduced that and made it more tolerable, then that would be a huge step forward. But on the first point of do these drugs help curb other addictive behaviors, there's certainly something clearly useful in that if it were true, because addictive behaviors are harmful and wouldn't it be wonderful if we had another therapeutic agent that could help us with them. But then it also raises another really important question, which is where else is this drug acting? And if this were to be true, then it might suggest that it's acting on the reward centers of the brain. And then could there be other downstream effects, like could it start affecting someone's ability to feel pleasure from a non-addictive activity? So appreciate that this isn't in your area, so we'll be looking into that more, and hopefully we can find some useful research about that.
Thank you for that explanation. But it also reminds me that the reward center in what is called hedonic eating is a very important component of obesity. You know, sometimes the drive from that reward center is something that is very difficult to subjugate, to control. And so the way I looked at that literature was that these medications may be having effects on reward, and that reward may pertain not only to alcohol or cigarette smoking, but also to the intake of calories. But again, this is not my area of expertise, so I'll leave it to others to comment.
Absolutely. And there's also a question about, what kinds of foods. I doubt that meat and potatoes and vegetables has the same effect on our reward centers as does crisps and pizza and other kinds of junk food. So it may be that by acting on the reward centers, that drugs like Ozempic are very neatly disincentivizing people from eating the very foods which everyone kind of knows he shouldn't eat that much anyway.
Yeah. Interesting thought.
And based on your current knowledge of these drugs, at what point would you consider starting someone on a prescription, and which drug might you choose of the four?
So the point, I think, is, first of all, to consider what is the patient's body mass index. So certainly if the patient's body mass index is greater than 35 kilograms per meter squared, they're in class 2 obesity. And that certainly would be the sort of body mass that we know over time is going to result in cardiovascular and cerebrovascular and even kidney problems. So apart from the diabetes, that is. So I think that's one factor. The second is, and this is how the medications are approved by the regulatory agencies, either a body mass index of greater than 30, which makes it class 1 obesity, or a body mass index of 27 kilograms per meter squared in the presence of a complication that's related to that overweight status. So, for example, high blood pressure, high cholesterol counts would be and of course maybe pre-diabetes as well, a higher fasting blood glucose, not quite fully in the diabetes range. So those would be the types of indications which certainly the regulatory agencies have approved these classes of medications. I also feel that patients should go through an assessment by a psychologist to make sure that there isn't a type of eating behavior disorder like bulimia or anorexia with marked fluctuation. And also, I think it would be appropriate for patients to have gone through an exercise and diet regimen to have, at least in quotes, failed the conservative approach. So if the patient's only lost 2% of the body weight after 6 months of real supervised weight loss, attending, some of the, I don't know whether they're available in the United Kingdom, but things like Weight Watchers, for example, and other types of programs, that would be something that I would want to see, that the patient has gone through that effort. And then the third question, I guess, is what medication would I consider? The two that I have had the greatest experience with are daily subcutaneous liraglutide injection or weekly subcutaneous semaglutide, which is Ozempic. And so those are typically the ones that I would focus on. And more and more patients are opting for the weekly subcutaneous injection. So that would likely be Ozempic or Mounjaro, or the weekly exenatide, with which I don't have any personal experience because, it sort of became available after Ozempic became available. And so one became more familiar with the Ozempic subcutaneous weekly injection.
Mm-hmm. Do you foresee a possibility that if these drugs prove to be safe, if no major complications crop up, that the threshold for their use will get lower and lower? Could these drugs even in the future be used for even those who are just overweight and not even in the obese category?
So from a societal standpoint, the way I would think about this is that there are very good epidemiological studies that show that the risk of cardiovascular and cerebrovascular disease, which are unfortunately major causes of death from heart attack or stroke or bleeds into the brain or whatever, those really start to become prevalent or more frequently observed in the general population at BMIs that are over 30 kilograms per meter squared. So from a societal standpoint, I do think that the decisions taken by the regulatory agencies ring true to me as a clinician and as a healthcare provider, because they are at the point where we know from population studies that they can have an impact on cerebrovascular disease and cardiovascular disease, or the patient who has a BMI of 27 already has some of those risk factors which are going to make them more prone to develop the complications in the heart and the brain that I mentioned. So I'm going to be a bit conservative here, and I think that where these medications have been placed seems to make clinical sense to me, and I'm not sure that it would be appropriate to drop the BMI standards any further.
Fair enough. What are the biggest questions that you want answered about these drugs as we continue to do more research on them?
So we just had a paper published that I really wish other people would do larger studies. So we studied 67 patients on liraglutide, which was treated, and they were treated for 16 weeks. And what we found was that 1/3 of the patients had no problems with stomach emptying for the entire 16 weeks. We studied them at baseline, at 5 weeks, and at 16 weeks. Completely normal.
How did you measure the stomach emptying?
We measured stomach emptying by putting a small amount of radioactivity in 2 scrambled eggs, and then we use an external camera to measure how fast food moves out of the stomach. And we have very robust normal data. So to put it into perspective, if it takes more than 174 minutes for half the meal to empty from the stomach, that means they're slow. Or if they have more than 25% of the meal remaining in the stomach, that means they're slow. So that's 25% at 4 hours. That means their stomach is slow. So I was saying 1/3 of patients, absolutely no problem. 2/3 of patients, at 5 weeks, they had marked delay in stomach emptying. They had like a paralyzed stomach. But among those, if we followed them for the next 16 weeks, half of those 2/3, became completely normal. So we end up with 1/3 of patients at 16 weeks continue to have slow stomach emptying. So this is only known for liraglutide given daily and studied over 16 weeks. We have no idea at the present time whether the same applies to the medications that are given subcutaneously once a week. We don't know if you follow the patients 3 months, 6 months, or 12 months, whether they still have slow stomach emptying. So I think that's because I'm a gastroenterologist, I also focus on not only the potential benefits of delayed gastric emptying on losing weight, but also I'm concerned about the potential for that side effect that we talked about earlier, which is that the patient's stomach continues to be slow and puts them at risk of the food during an anesthetic procedure being aspirated into the lung and causing real problems. So that's the one burning question I'd like to have answered. And of course, the other question is, what is the long-term safety? And that might require 5-year studies. And also, what's the long-term efficacy, particularly in patients who are able to stop the medication? And how good are we at teaching patients the new lifestyle interventions that they need to maintain in order to retain that degree of weight loss? So those are some of the questions I'd love to see addressed.
Yes. In the proportion of patients in your study that had prolonged delayed emptying of the stomach, did that show up clinically? Were they more nauseous, or did they have any other clinical side effects?
Some of them did have nausea, but in some respects, that nausea may have actually facilitated the reduction of their food intake. Another way in which it manifested is because we were studying these patients very carefully under very strict control in a clinical research trials unit, we were able to modify the degree to which we increased the dose so that we had a significant dose which they could tolerate without the nausea. So even though the dose, you see, the way you give this medication, that particular medication, you start with 0.6 milligrams, and then you go after 1 week to 1.2. After 1 week, you go to 1.8, then 2.4, and by 5 weeks, you're at 3 milligrams. So if the patient had very significant nausea, we could slow that dose escalation so that they could tolerate it better. But yes, we did see some of the symptoms. Collecting those symptoms in a very detailed and prospective manner was not one of the goals of our research study. So the best I can give you is a gestalt, if you wish, as to what the patients experienced.
Mm-hmm. And in general, these drugs, they have a standard titration plan of dose like you laid out, or is there any scope to give, for example, a minimum effective dose?
So in clinical trials, there's a standard dose escalation, and also the regulatory agencies have a very strict dose escalation, as I mentioned, for that particular drug, liraglutide. In clinical practice, yes, I do know several colleagues will sometimes say, as I was doing the dose escalation, patients were doing really well when they were on 80% of the maximum dose and they had started to lose weight. So when they went up to 100% and they got side effects, I reduced the dose again. And in clinical practice, I maintained the dose that the patient was able to tolerate, and then achieved the benefit, not significant side effects, and yet the patient did lose weight. So there again, that's where working with the patient's physician, the patient can also have opportunities to individualize the dose that works for them.
Yeah, they can have a much more pragmatic regime.
Yeah.
Well, Michael, thank you for answering all of my questions. You've been very patient. Is there anything else that you would want people to know about these drugs that you think is particularly important?
Yeah, I would summarize as saying that, yes, we have spent quite a lot of time talking about potential side effects, and we want to avoid putting any patient in danger. But I think we need to look at the positive side of it as well, that these medications really, for the first time in my medical career, I think we have the types of pharmacological agents that have very significant impact on obesity and type 2 diabetes, almost to the point where has been achieved, for instance, with sleeve gastrectomy, which is a type of operation called a bariatric operation that's commonly used in patients with obesity. So I do think that we need to take the positive side of these medications, but still make sure that the patients are safe. And, if there are symptoms, for instance, that suggest side effects, it would be good for the patient to report those to their doctor and do a stomach emptying test to check to make sure that the patient is not at significant risk.
Yeah. I have to admit, when I first heard about these drugs, and I was discussing them with an evolutionary psychiatrist also in America named Randy Nesse a couple of months ago, and my first intuition was, what are going to be the downstream biological effects? And there's no such thing as a free lunch. And those are the kinds of thoughts I had. But having looked into it so far and having discussed with yourself, so far it seems potentially like very exciting and like a very huge net positive for treating a set of conditions which are a huge burden on our health system and obviously a huge burden on people's individual lives as well.
Absolutely. I mean, I think it's important to remember that the consequences of long-standing obesity and type 2 diabetes are really very significant from the perspective of longevity and, as we mentioned earlier, cardiovascular and cerebrovascular diseases such as stroke. So trying to avoid those types of problems, I think, and also giving patients a better lifestyle in general is something that we as physicians should continue to try to achieve.
Perfect. Well, Michael, we'll continue watching this space. Thank you very much for your very clear and detailed information.
Thank you for including me in your podcast.
Thanks so much for listening this week. If you've got any feedback, as always, do get in touch. If you enjoyed the episode, why not give us a rating on Spotify or Apple Podcasts, because it really helps other people to find us. If you want to get in touch, you can find us on Instagram or Twitter, or you can drop us an email. And if you value the show more generally, why not buy us a coffee? Thanks so much.